Yes, very good evening, my dear learners. Hope you all are doing well. So let's get connected today with a marathon, which we are going on at Unacademy, which is basically driven towards images. Okay. So basically, what we are considering is more and more of the image related questions, and we'll try to solve the MCQs focused around those images. Okay, so let's get started. I'm your mentor at Unacademy. I'm your mentor at Unacademy, Dr. Reena. Yes, so coming up with the first question, let's hear the question pehle and then I'll be showing you the image related to it. ठीक, so the question says that there is a hello Vicky, hello, good evening, beta. Hello and good evening. ठीक है. So there is a healthy 30-year-old woman who is referred for a life insurance physical examination. So just a routine physical examination which we have to go for life insurance. Hello Raghav, Dopamine, Jessir, Short Surbhi, Nancy. Hello beta. History reveals that there is no history of smoking and there are vesicular breath sounds. Okay, so there are vesicular breath sounds. You know that vesicular breath sounds are actually normal. And in a normal spirometry, which I'm going to show you the tracing, which one depicts the expiratory reserve volume. Okay, which one depicts the expiratory reserve volume. So here is the image to you. Which one is the expiratory reserve volume? Yes, Raghav, I am also looking forward to teach you all, right? ठीक है, तो कौन सा वाला इसमें is telling you the expiratory reserve volume. So मैंने options कौन से दिए हैं? These options are C, D, E, C plus D or E minus D. C, D, E, or whether it is C plus D or whether it is E minus D. Yes, because it is after a long time, but at least we are again together, right? Yes. So what is the correct answer? Anybody can come up with what is the correct answer? No image. 1 minute. 1 minute. There's no image. 1 minute. Let me see what's the problem. Yes, am I audible? Hmm? Yes. So I'm audible now finally. Yes, 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 yes. So finally I'm audible, boys and girls. Please get connected. I am audible. So let's get started. So we have got a long session and we wasted around 10 minutes in technical issues. Okay, so let's come back. So yes. So this was the question where I asked you what is going to be ERV, right? What is going to be ERV? Whether it is going to be A, it is going to be B, it is going to be C, it is going to be E minus D, right? It is going to be E minus D. So finally, let me give you the correct answer because we wasted a small amount of time. Yes. So the correct answer is E minus D, right? The correct answer is E minus D for ERV. What is this E minus D? What is this E and what is this D? Okay, what is the E and what is the D? So this E is your FRC and D is your residual volume, right? It is FRC minus residual volume. So, this is a simple question, which is a very typical INICT pattern of question where you will be given, you know, a simple case presentation and asking the physiology behind, right? So, by definition, what is FRC? It is the volume of air remaining in the lungs at the end of your tidal respiration, or your tidal expiration, what you can say. Whereas residual volume is the air remaining at the end of your forceful expiration. And we know that FRC is equal to ERV plus residual volume. And therefore, ERV is going to be FRC minus your residual volume. Now, as far as your FRC is concerned, right? This FRC is also called as a buffer volume. It is also called as a buffer. Why a buffer? Because it maintains the exchange of gases at the end expiratory position. When you have just stopped expiration and when you are about to take the next air in, at that time also the exchange of gases is maintained and the partial pressure of oxygen and carbon dioxide is maintained. Therefore, it acts as a buffer. Another important thing is that it is also called as a relaxation volume, right? It is also called as relaxation volume. Why relaxation volume? Because at the end of your respiration, when the entire respiratory system is relaxing, that means your lungs and your chest wall, okay, your lungs and your thoracic cage, both of them are relaxing. It is the volume of air that is maintaining the elastic recoil. It is balancing the elastic recoil of the lungs and the chest wall. You know that the lungs and the chest wall both are elastic, having elastic recoil properties, with the lungs who have got a property of collapsing and the thoracic cage has got a property of over expanding. But that is maintained at the end by this relaxation volume, which is your FRC. So FRC is one of the very, very important MCQ. Right? Now, something important is that, like, suppose I give you an MCQ. Okay, let's take an MCQ. Suppose I say, which volume, okay, which volume can be measured by simple spirometry? Which volume can be measured by simple spirometry? Now see, normally what do you get, that which volume cannot be measured by spirometry. अभी मैं आपसे पूछ रही हूँ कि which can be measured, ठीक है? And I'm giving you the options. Suppose vital capacity, FRC, peak expiratory flow rate, or whether it is residual volume. Yes, Javed, in this particular thing, it is the vital capacity which can be measured by a simple spirometry, because PEFR requires peak expiratory flow rate, RV can never be measured. So you first measure your FRC and uske baad you can find out RV and TLC, right? Now, this was the static lung volume and capacities, which we simple did by a simple spirometer. That means inspiration, expiration, inspiration, expiration, right? This is the vital capacity, which we called as a simple vital capacity with a spirometer. There is no stretching of the expiratory limb. But here you can see that we have stretched out the expiratory limb, isn't it? We have stretched out the expiratory limb. So when you have done a stretching of the expiratory limb, you are focusing towards your forced vital capacity, which is also called as the timed vital capacity, a forced vital capacity or a timed vital capacity. What is the difference between both of them? Vital capacity is the volume of air which is taken in with maximum inspiration and expired out with a forceful expiration. But when you ask the person to expire as rapid as possible, so as rapidly, as complete as possible, completely. So rapidly, completely, and forcefully. So when you are using these three adjectives, as rapidly, as completely, as forcefully, you are stretching out the expiratory limb. That is forced vital capacity. And I'm concentrating more on this expiratory limb because I want to find out how is the expiration of the person, because I'm interested in my Tiffany's index, which is FEV1 by FVC, which is the cornerstone to distinguish between obstructive and restrictive airway diseases. So you can see if this is a normal vital capacity, right? A similar graph, but just a reduced one, is our restrictive lung disease, and a stretched out of the expiratory limb are obstructive lung diseases, right? Now, this is a clinical spirogram, right? This is a clinical spirogram where on the x-axis you have time and on the y-axis you have got the volume that is expired. Okay, you've got the volume that is expired. This is very simple to find out FVC, FEV1, the ratio between FEV1 to FVC, that is your Tiffany's index, and also the mid-expiratory flow rate. These also come as your calculation-based questions, right? So this is a clinical spirogram. On the other hand, what is this? This is your flow loops, right? These are your flow loops. Remember, in the flow loops, we are interested in volume, which we take on the x-axis, and on the y-axis, flow rate in liters per second. So you are basically concentrating in the flow rates. You are basically concentrating on how much volume in how much duration. So below this baseline is going to be your inspiration, and above the baseline is going to be your expiration. From the point extreme right, you ask the person to take a deep inspiration and fill up the lungs till you get a TLC. Now the person is going to start expiring. So he's going to expire with maximum expiratory effort till you reach a peak, that is PEFR. This portion, boys and girls, is called as force dependent or effort dependent, right? This portion becomes the effort dependent expiration. That means more forcefully you expire out, more efforts you give out, more will be the peak of that PFR. But after that, when the volume is reduced, right? The volume is reduced. This is effort independent. This portion becomes effort independent. Okay. So effort dependent, effort independent. Another important thing, on the extreme right is the residual volume, extreme left is the TLC. Remember, we don't get TLC and RV. We don't find out in the by the spirometry procedure. This we have taken to show you on the graph because this comes as calculation based question. ठीक है, so आपको पता होना चाहिए कि कौन सा point will be RV and कौन सा point will be our TLC, right? So effort dependent and effort independent portion. Now, This is called as a pneumatograph. What is this? This is a pneumatograph. What do you mean by this? This is, you can show that more you increase the inspiratory effort, more is going to be the inspiration. So more you increase the inspiratory efforts, more is going to be your inspiration, right? More is going to be your inspiration. But if you are using, right, if you are using uh, expiratory efforts, right? If you see expiratory efforts, so this expiratory efforts, what you can see, if you increase your effort of expiration, right? If you increase your effort of expiration, this effort dependent portion will show separate graphs. The effort dependent portions will show separate graphs, but the effort independent are going to merge up. Okay, the effort independent are going to merge up. So this is a typical pneumatograph, where you see that if you keep on increasing the inspiratory efforts, you're going to get a different inspiratory curves. But in the case of expiration, only the expiratory or the effort dependent portions will be different, but the effort independence will be fused up. This is what is called as a pneumatograph. Now, this is another very interesting thing, which are obstructive disorders. You know that obstructive disorders are characterized by a flattening, right? A typical flattening or a dog-legged appearance or a concavity, right? So you can see that there is a concavity over here, but yahan par there is no concavity. Okay, there is no concavity over here. So here you can see that this is the normal PFR. So we can see that the PFR is reduced, isn't it? There is a decrease in the PFR. But here we can see that the problem is not much with the PFR, but there is more problem in the concavity. That means both of these are a type of, okay, both of these are a type of obstructive airway disorders. But this is mainly your large airway disease. Okay, it is mainly your large airway disease. Here the site of obstruction is your larger airways. So when there is typically a decrease in the PFR, right, but there is no concavity, right, there is no problem with concavity. That means small airway disease is not a problem. But if there is a decrease, I mean, if the PFR is almost normal, but there is a concavity, here the problem is basically a small airway disease. Okay, a small airway disease. So this is a typical difference. You can get mixed patterns. Many of the times you see you get mixed patterns, small and large airway disease. But if only reduction in PFR is there, it is typically large airway disease. If there is concavity, it is typically a small airway disease. Now here you can see that you got a decrease in the height. So decrease in PFR plus concavity. So this is your small and large airway obstruction, right? It is your small and large airway obstruction. Got it? Now, in the case of the restrictive disorder, you basically get a decrease in the PFR. That means the shape is normal, but there is just a reduction in the height of the curve as compared to normal. What is the reason? There is no obstruction, there is restriction, there is a difficulty in inspiration. Now we know that in case of restrictive disorders, there is a decrease in the compliance. There is a reduction in the compliance. The person is not able to take in air. So if the lungs are not filled with air, how can we expect the expiratory effort to go on? If we want to have a good expiration, there should be a good inspiration, but the volume of air is less and therefore he cannot take up good expiratory effort. So decrease in the height, large airways, concavity, small airways, combination, both small and large airway obstructive diseases. And if it is only a decrease in height with the shape being normal, it is restrictive, right? So is it okay, everybody? English, right? If it is okay, yes. G2 Meena, is there any problem, beta? Do you want me to speak only in English? Do you want me to speak only in Hindi? What do you want? Okay, so let's jump on to the next question. This is a curve, right? You can see that on x-axis we've taken the partial pressure of oxygen. On the y-axis we've taken the oxygen content, which is in ml per 100 ml. Now let's look on to the question. There is a, ठीक है दोनों यूज करती हूँ, okay, there is a 19-year-old man, okay, 19-year-old man who is coming to the emergency department and he has complaints of shortness of breath. ठीक है, he has got complaints of shortness of breath. And if we look on to the oxygen hemoglobin dissociation curve, so this is normal. ठीक है, जो ये वाला है ये नॉर्मल है, A is normal, एंड जो पेशेंट है उसका कर्व यहां शिफ्ट हो चुका है B को, द कर्व इज शिफ्टेड टू B. व्हाट इज द कॉज? कार्बन मोनोऑक्साइड पॉइजनिंग, exercise, hypoventilation, increased body temperature, or the recent blood transfusion with a blanked blood, मतलब stored blood. yes, क्या आंसर होगा इसका? A B C D E. देखो लेफ्ट शिफ्ट है, ए वाला बी के तरफ चला गया है. व्हाट इज द आंसर? व्हाट इज द आंसर? ओके, सो द करेक्ट आंसर ओवर हियर इज not A, it is not carbon monoxide poisoning, it is a history with a recent blood transfusion. That means stored blood is being given to the subject. Stored blood is being given to the subject, not B. Exercise beta is going to cause right shift. Exercise always causes a right shift and not a left shift, a right shift. ठीक है? It is stored blood. Why not carbon monoxide poisoning? See, the blood bank is low in 2,3 biphosphoglycerate. That means the DPG levels are reduced in the stored blood, because we know that in the stored blood the metabolism is decreased, which is going to shift the curve to the left, right? It is going to shift the curve to the left. Left curve can also be seen with carbon monoxide poisoning, isn't it? It can also be seen with carbon monoxide poisoning. But here carbon monoxide poisoning is not the cause. Why not the cause? Because if you look over to the carbon monoxide poisoning, which is shifting the curve to the left, always look over to the oxygen content. Biggest thing, always look over to the oxygen content. If it is a left shift curve and you are confused, it could be carbon monoxide poisoning. No, always look over to the oxygen content, because oxygen content is going to be grossly reduced in carbon monoxide poisoning. You know, it is a type of anemic hypoxia. Carbon monoxide is a type of anemic hypoxia. So actually ये करता क्या है? What does it do? This carbon monoxide has got about affinity 250 times more to hemoglobin as compared to oxygen, right? It has got affinity about more than 250 times to oxygen as compared to hemoglobin, as compared to oxygen. So once it binds to the oxygen binding site, it does not allow new molecules of oxygen to bind, right? It does not allow new molecules of oxygen to bind. So this oxygen cannot bind. Any new molecules of oxygen cannot bind. Now, as this carbon monoxide binds to hemoglobin, oxygen becomes very scared now. It comes to know that somebody has come to, competitive. So this oxygen, which was already bounded, does not get released. Does not get released. So the new molecules of oxygen cannot bind. The bounded oxygen cannot get released, and the curve gets shifted to the left. So left shifting with carbon monoxide poisoning, always remember that we are going to look towards the oxygen content. ठीक है? Now अगर आपको सीखना है कि how could be, how can we learn this right shift and left shift. So see, suppose this is the normal oxygen hemoglobin curve and this is the right shift, ठीक है, and this is the left shift. So right means what? Right shift is more. What is more which is going to cause right shift? राइट मतलब आप ऑक्सीजन कहां दे रहे हो? टिश्यूज को, ठीक है? तो टिश्यूज को ऑक्सीजन कब लगेगा? आर. व्हाट इज आर? आर इज more of carbon dioxide, more of H plus, more of DPG. So the conditions like acidosis, the conditions like anemia, A, and another A, altitude, which is high altitude. So these are the conditions which are going to shift the curve to right. Hello Arpit, any help from my side? Hello Arpit. So any help you need from my side, you can let me know. So right means more. Left means what? L. Left. It is less. Okay, less. What would be less? Less of carbon dioxide, less of H plus, less of DPG. So as simple as such. Right is more, left is less. Right? And remember one very, very important value, that is partial pressure of oxygen 60 mmHg. Till the partial pressure of oxygen is 60 mmHg, there is going to be 90% saturation of oxygen with hemoglobin, and the person will never develop hypoxic hypoventilation, right? So partial pressure of 60 is very, very important. Here you is going to see around the partial pressure being 60 and percent saturation is 90. So right shift, left shift, carbon monoxide poisoning, fetal hemoglobin also left shift. These are very, very important topic in physiology. So let's move on to the next question. There is again an image. Now you can see that this is the image which is coming from the parietal cell of stomach, right? This is the image which is G2, it will be left shift beta. Left shift in carbon monoxide. With carbon monoxide, it is left shift. Now, this is the parietal cell of stomach. You can see X, Y, Z. X, Y, Z. What are these X, Y, Z? Options given are the following. So, you know that what is parietal cell? It is the site where you're going to bring about HCl secretion, which is an example of a primary active transport. So, what would be X, Y, and Z? Cyanide poisoning results in histotoxic anemia. It results in histotoxic anemia. Right? Histotoxic anemia. That is different. Right. So, what is the correct answer for this? Anybody? Oh God. Anyone who can give the correct answer? What would be this? A, B, C, D, E. Anyone? So, the correct answer is E. The correct answer is E. That means chloride X. Okay, chloride X. Y is hydrogen ion and Z is potassium. Right? See this now. Is it clear? P, is it clear? Now let's see. Yes. Now this is the parietal cell. Okay, this is the parietal cell of stomach. Right? This is the parietal cell of stomach. You can see, yes, you can see that in the parietal cell of stomach, there is a primary, this is always first look over to the side of the basolateral side, interstitial fluid, and towards the luminal side, right? Towards the luminal side, you're going to have a primary hydrogen ATPase pump. This primary hydrogen ATPase pump is going to pump the hydrogen more towards the lumen. How is the hydrogen secreted? You know that carbon dioxide will combine with water into the cell. Okay, carbon dioxide will combine to water into the cell, and this will liberate your carbon dioxide. This will see carbon. This is going to form your H2CO3. This carbonic acid dissociates into H plus and bicarbonate. H plus and bicarbonate. So this is the H plus ion, which is going to be transported by a luminal transport towards the lumen with a primary hydrogen ATPase pump, which is also secreting potassium, taking it inside. But the potassium can be recycled. Okay, you can see that the potassium can be recycled very well. Apart from this, the chloride which is liberated, the chloride and the bicarbonates, the chloride is going to be exchanged with your bicarbonates. Okay, the bicarbonates and the chlorides, they get exchanged. Chloride will come down its concentration gradient. So finally on the luminal side, you will have hydrogen and chloride and water. So this is HCl secretion. Arpit, cyclic AMP is used by histamine. Yes, cyclic AMP is used by histamine. Now, I will be showing you the next question, that is going to be an image which shows ionic distribution of potassium, chloride and sodium across the cell membrane. Okay, potassium, hydrogen, chloride across the cell membrane. The concentration of each ion is represented by its size. So you can see that the concentration of each ion is represented by its size. That means bigger the size, more will be the concentration, right? Bigger the size, more will be the concentration. So you have to tell me A, B, C or D. Which one of this is actually representing the distribution of sodium, potassium, chloride across a living cell membrane? Okay, which one is telling us the concentration of sodium, potassium and chloride across the cell membrane? Yes, very good, Vishwa. Very good. So you came up very promptly with the correct answer. Very good. So you came up promptly with the correct answer. It is B. So you can see that this is my ICF, where the potassium is more, and this is my ECF, where the chloride and the sodium concentration are more. Also remember that in the ICF, you have got more amount of magnesium, and you also have more of the phosphates, and you have got more of proteins. Whereas ECF will have sodium, chloride, it will have bicarbonate, and it will have calcium. Okay, next one. Now, again, I'll be showing you an image. So just uske pehle we look into the question. There is a 34-year-old woman who is coming with recurrent nausea and vomiting. There is a gastrointestinal motility disorder suspected. Okay, a gastrointestinal motility disorder is suspected, which is confirmed by an electrogastrogram. So I'll be showing you the electrogastrogram. See, this is the electrogastrogram. So this is the normal, that is X, where we can see that we are getting spike potentials. The spike potentials which are reflecting the normal depolarization, and a drug is administered. When that drug is administered, you are getting a graph like this, a Y, that is a graph which is representing this absence of this spikes, right? Now the question says, what drug is likely causing the trace Y? It is adrenergic reuptake inhibitor. It is agonist of L-type calcium channel. It is cholinesterase inhibitor. It is a somatostatin receptor antagonist, or it is sympathetic antagonist. What it could be? Yes, anybody? So the correct answer is A, that is adrenergic reuptake inhibitor. Very good, Vishwa. Very good. Yes. So Vishwa has given the correct answer. Very good. Yes. Now you must understand this very nicely, that this means absence or inhibition of the motility, right? Inhibition of motility. Now, when you want to be very clear with this, you must remember that the gastrointestinal smooth muscles, they exhibit an inherent spontaneous activity called as the slow waves, right? Slow waves. These slow waves are called as BER, that is the basic electric rhythm, which is caused by or brought about by the interstitial cells of Kajal, which are the pacemaker cells, interstitial cells of Kajal. They are supposed to be the pacemaker cells. Okay, pacemaker cells. Now we know that the GIT motility is inhibited by the sympathetics. The amplitude, the plateau durations are inhibited by the sympathetic. So when you are giving an adrenergic reuptake inhibitor, it is increasing the appearance or the presence of norepinephrine. That means if more amount of norepinephrine is present in the varicosities, then the amount of availability of norepinephrine is more. That means the inhibitory effect will be more, right? So the decreased slow wave activity is going to decrease the frequency of the spike. That means decrease the GIT motility, right? So you must always remember that in the case of GIT, the sympathetics are stimulatory, whereas the parasympathetics are excuse me. In the case of GIT, the sympathetics are supposed to be inhibitory. Okay, the sympathetics are inhibitory and the parasympathetics are stimulatory. So this thing should always be understood to you, right? This is inhibitory and this is stimulatory. Yes. So this is very, very important. Now the next question. The question is related to this graph where you can see that on the x-axis, there is the renal arterial pressure. On the y-axis, there is the regulation being shown of the renal blood flow and of the GFR. So it is the question which is related to autoregulation. Now a question says that a 40-year-old man, okay, there is a 40-year-old man, acute hypertensive event, has got a renal arterial pressure between 120 and 150, okay, between 120 and 150. The resulting renal blood flow and GFR are shown on the graph. Which of the following physiological mechanism is most responsible to maintain this patient's renal plasma flow despite the changes in the renal arterial pressure? So the question is asking you that what is responsible in this patient to maintain his renal blood flow and GFR despite of changes in the renal arterial pressure which is increased. Options are autoregulation of the renal arteriolar diameter, release of aldosterone from the adrenal cortex, release of epinephrine from the adrenal medulla, reactive hyperemia, or sympathetic mediated vasoconstriction of the renal arterioles. So what is the correct answer? It is associated with autoregulation. It is associated with autoregulation. So the correct answer is A. Okay, the correct answer is A. That is auto-regulation. Okay, auto-regulation. Now, yes, no, it is A, beta. It is A, auto-regulation. That is brought about by adjusting the renal arteriolar diameter. Now, let us understand this. Now, there are two important mechanisms. One is the tubuloglomerular feedback mechanism. Tubuloglomerular feedback mechanism that is basically regulating GFR. Okay, that is basically regulating GFR. And the other important is the myogenic mechanism that basically regulates your renal blood flow. Okay, that regulates your renal blood flow. Now, what is this myogenic mechanism? Now, whenever there is an increase in the pressure, okay, mean arterial pressure, right? When there is an increase in the mean arterial pressure. So, pressure means what? Stretch. It is a mechanical stimulus. So, it is going to cause the stretching of the smooth muscle cells. Okay, the stretching of the smooth muscle cells of blood vessels, that is the renal artery or the renal blood vessels, renal artery. So it caused the stretching of the smooth muscle cells. This stretching is going to cause the opening of the stretch sensitive calcium channels, opening of the stretch sensitive calcium channels, which is going to result in the calcium influx. Now, once there is calcium influx, what will happen? This calcium will bind to calmodulin, isn't it? There will be the calcium calmodulin complex. That calcium calmodulin complex will then bring about increase in the activity of the myosin phosphorylases. Okay, and there is going to be your smooth muscle contraction. So when you are causing smooth muscle contraction, that means you are causing vasoconstriction. And do we remember that R is inversely proportional to fourth power of R, wherein this capital R is resistance and the small r is your radius. So what have we done? We have decreased the small r, that is radius, and therefore we have increased the resistance to the flow of blood. Therefore, despite of increase in the blood pressure, the blood flow will not increase. So even if there is an increase in the blood pressure, the blood flow will not increase because we've brought about vasoconstriction. That is what is the myogenic mechanism for the renal blood flow. The tubuloglobular feedback mechanism operates at the level of macula densa. Where is macula densa? It is the part of the juxtaglomerular apparatus, and these are the modified cells of DCT which behave as chemoreceptors and they sense NaCl. So once there is a decrease in the delivery of NaCl, there is going to be communication of the macula densa cells to the renin secreting cells, that is the juxtaglomerular cells, and they will activate the renin angiotensin aldosterone mechanism. And you know that angiotensin 2, it is a very, very potent vasoconstrictor. And remember that it prefers efferent arterioles more than the afferent arterioles. Okay, it prefers the efferent arteriole more than the afferent arteriole. A selective constriction of the efferent arteriole, and with a mild to moderate efferent arteriolar constriction, we will have an increase in GFR. The other functions of angiotensin 2 is secretion of aldosterone. It also causes stimulation of thirst by stimulating two important organs, subfornical organ and the organum vasculosum of lamina terminalis. These two organs which are present outside the blood-brain barrier, subfornical organ and the organum vasculosum of lamina terminalis, and it also acts on the kidney to bring about sodium and water retention. So these are the important functions of your angiotensin 2 and the two mechanisms which are important to regulate your constant GFR and renal plasma flow in the range of 80 to 180 mmHg despite of changes in the blood pressure. Right? So now let's look on to the next image. If a drug antagonizes the voltage gated sodium channels, okay, which is administered to a neuron, it is going to affect which phase of action potential. It is going to affect which phase of action potential. So phase 1, phase 2, phase 3 or phase 4. What is the correct answer? So you are giving a drug which is antagonizing voltage gated sodium channels. Yes, we know that sodium channels are associated with depolarization. So the correct answer is B. So if you are giving the drugs which are going to inhibit the sodium channels, you're going to affect the depolarization. Now, I ask you one question. My question is, you know that this is the action potential. Suppose this is neuron minus 70 millivolt, and here will be a spike at plus 35 millivolts. Suppose you prevent the closure of, okay, you prevent the closure of the sodium channels. That means you do not allow the sodium channels to close. What will happen? Obviously, there will be increase in the upstroke of action potential. The depolarization will increase and increase and increase. So this plus 35 can reach up to what value? Plus 45, plus 55 और plus 65. ठीक है, तो अगर आपने सोडियम चैनल्स को क्लोज नहीं होने दिया, इसका मतलब आप अपस्ट्रोक को बढ़ा रहे हो. What can be the maximum voltage we can obtain? So here the correct answer is plus 65. Plus 65 is the correct answer, because plus 61 to plus 65 is the Nernst potential for sodium. It is the Nernst potential for sodium. And the sodium channels will remain open till sodium comes inside along its concentration gradient. Once the Nernst potential reaches plus 65, that means equal to that of sodium, that means at this particular point the resting membrane potential will be only due to the sodium ions. That is the point where there will be an equilibrium established, equilibrium of sodium ions established inside and outside, and now there will be no net diffusion of the sodium ions, and that is what is actually the Nernst potential, the diffusion potential at which now there is an equilibrium and there's going to be no further diffusion of ions, right? That is the Nernst potential, right? So action potential, general physiology, again important topics. Now let's look on to an image based question again. So this is the image, okay? This is the image where on x-axis there is time, on y-axis there is tension. The question says the image shows a twitch of a skeletal muscle contraction. You know that contraction, relaxation. This is a twitch after being stimulated at time 0. Now, what did you do? That you stimulated at time 0, and again within a second, a similar stimulus is given 30 milliseconds later. So after 30 milliseconds, you are giving another stimulus. What are you expecting? Okay, what are you expecting? So this is a twitch, and suppose somewhere over here, after 30 milliseconds, you gave another twitch, another stimulus. What are you expecting? A second contraction of higher tension, a second identical twitch contraction, failure of the muscle to contract, some period of fused tetanus, or two short twitch contractions. Remember, this is the first prof practicals of nerve muscle physiology. No job, it cannot be C, it has to be A. C over here now. This is what occurred. You gave the second stimulus 30 milliseconds after the first. So when you gave the second stimulus in this time, what happened? You got the second stimuli to take benefit of the first one. So whatever changes which were brought about by the first stimuli, that is decrease in viscosity, increase in temperature, increase availability of the calcium ion, they were all utilized by the second stimuli, and therefore we got a force of contraction even more than the first one. This is what is called as beneficial effect, or this is what is called as the effect of two successive stimuli. Okay, effect of two successive stimuli, and the effect of the second stimuli depends upon the duration at which it is given. आप कौन से time पर दे रहे हो? So if you are giving it like this, if you are giving it during the latent period of the first one, if you are giving it during the latent period of the first one, the second happens to fall in the absolute refractory period. If you give during contraction, mid contraction, during relaxation, these are the points where you're going to get the second curve, which will be of higher amplitude than the first one. This is the effect of two successive stimuli, right? Whereas the feature of tetanus, okay, the feature of tetanus which you get is like this: fusion of contractions. So when we speak of tetanus, it is the effect of multiple stimuli. It is the effect of multiple stimuli, and you can calculate tetanizing frequency. It is 1 upon contraction period. Okay, it is 1 upon contraction period. Now let's look on to the next question. Now I gave you a graph over here. Yes. See, I've given you a graph over here. This is the graph which is of a hormone, right? This is the graph which is of a hormone. Which hormone it could be? Okay, which hormone it could be? The peak of this hormone you can see is almost between 4 a.m. to 10 a.m. So this is which hormone? Yes, Shahu has come with the correct answer. It is cortisol. Yes, it is cortisol. So this is very, very important, graphs which are related. It is cortisol. Now, which can be these, which can be this now? Even this can be cortisol. It can be growth hormone. It can be prolactin, or it can even be your thyroid hormone. What is this now? What is this? The second one. Yes, Anjana, very correct. This is typically our growth hormone. If you see which is increasing in exercise, if you see that it is increasing midnight, that means more towards your NREM. It is your growth hormone. Now, this particular image is also very, very important as far as reproductive physiology is concerned. So you can get an image-based question, and you should know that the pre-ovulatory period is a phase where there is more amount of estrogens, more amount of FSH. The post-ovulatory period is progesterone. Progesterone and an LH surge. Very important graph images related to reproductive physiology. There can also be a graph that is showing you a rise in temperature and asking you the effect. Again, you must remember that there is a thermogenic effect of progesterone. A thermogenic effect of progesterone. So this is important with the menstrual cycle. Yes, Sapna, it's very important. Now, even this graph is very, very interesting. You can see that this is the normal curve. And on the x-axis, we've taken the diameter. On the y-axis, we've taken the number of the RBC. So as compared to normal, we can see that there is a decrease in the number of RBC on both sides. But if there is a right shift, that means the diameter is more. So macrocytosis, for example, megaloblastic anemia, pernicious anemia, And if it is left shift, that means a decrease in diameter, it is microcytosis. For example, iron deficiency anemia, thalassemia, that on. Right? So again, very, very important image. Now, there is a 66-year-old man who is brought to the emergency department because of shortness of breath and confusion. The pulse is 98 per minute. The blood pressure is 109/73. He is oriented to person but not to time and place. A graph of his breathing is shown. So what graph is shown? A gradual hyperapnea, hypoapnea, followed by a period of apnea, and then again hyperapnea and apnea. So this is the typical graph that is shown. Hyperapnea, hypoapnea, followed by apnea, and again hyperapnea. So what is this condition? Ventricular gallop, rib fracture, barrel chest, or a fruity breath odor. What it could be, boys and girls? Anybody with the correct answer? So the correct answer is A, that is ventricular gallop, which is developed in patients with heart failure, a condition that causes severe dyspnea with Cheyne-Stokes breathing, as is shown in this case. Right? So again, very important. So what do we come over here? That abnormal types of breathing patterns, abnormal breathing patterns जो होते हैं, that should be studied. Abnormal breathing patterns should be studied. Okay? Now, what is this? And you will get this in which type of sleep? It is NREM, stage 1, stage 2, stage 3, or it is REM. What is this? This is EEG, that is electroencephalogram, that is EEG. This is typically called as the sawtooth pattern. It is typically called as the sawtooth pattern. कौन से स्लीप में आपको मिलता है ये? Yes, very good. You get it in REM sleep. This is a typical of REM sleep, right? The sleep spindles are the NREM sleep, the K complexes, right? So that means if we look upon to sleep, we have got REM sleep and NREM sleep. REM, which is also called as a paradoxical sleep. What is the paradox? The brain is active and therefore there is presence of beta waves. You also get PGO spikes, pontogenito-occipital spikes. The neurotransmitter is acetylcholine. Very important feature is dreams are registered. Most important feature that the dreams are registered. However, there is irregular heart rate, there is irregular respiratory rate, there is a reduced muscle tone. There is a reduced muscle tone, but you can get irregular muscle activity like the extraocular muscles. PGO is pontogenito-occipital spikes. Myra, pontogenital, from the pons to the lateral geniculate body to the occipital cortex. Pontogenito-occipital spikes. That is okay. NREM sleep is a true sleep, a physiological sleep, which is actually relaxing to the body, to the mind. And very important feature is that the dreams are not registered over here. That means when we get up in the morning, whatever dreams which we are recollecting are of the REM. They are not of NREM. right? They are not of NREM. Now, recently, this NREM has been divided as stage N1, N2, and N3, right? N1 is characterized by theta waves, which are 4 to 7 hertz. N2 is characterized by the sleep spindles and the K complexes. And N3 is characterized by large amplitude delta waves. Remember, they are of the largest amplitude, right? They are of the largest amplitude, but they are having least frequency. Least frequency, right? Another very, very important thing regarding sleep is the various neurotransmitters that are involved in sleep, the various neurotransmitters that are involved in sleep. So you can see that when there is increase in histamine, okay, when there is increase in histamine and decrease in GABA, there is increased activation of the thalamus and cortex resulting in waking. Therefore, when we use antihistaminic drugs, there is sedation. One of the most important side effects of antihistaminic drugs is sedation. Increase GABA, decrease histamine, decrease activation, NREM sleep. Right? Brainstem में when there is increase in the norepinephrine, serotonin, decrease in acetylcholine, waking, but increase in acetylcholine is REM sleep. Sapna, your question is alpha waves. Alpha waves are the waves which we get when the eyes are closed, right? Suppose you are going to sleep and you keep your eyes closed. What will happen? There will be a decrease in the attention. The focus of attention will decrease. You will have some amount of wandering thoughts, right? Some amount of wandering thoughts are going into the mind. The mind is totally relaxed, but you are not paying attention to anything special. So as if calmness, meditation, that kind is what is your alpha waves, right? So boys and girls, this is all for today. I hope you enjoyed the session with few technical issues which we solved ASAP, and I'm really happy that you got well connected. Please stay tuned. Do remain connected. Give me your suggestions, what you want to study, and let us, study with full planning, with timetable, with persistence, right? But amidst of every challenge, always remember that your mental health and your physical health are equally important. So do give time to relax your body, your mind. Do something that really makes you happy, because if you keep on working and working and studying, the quality of your study will deteriorate. So always take some time to relax, calm down. And one important thing is, before you go to sleep, make a timetable for tomorrow. Never go to sleep without making a timetable. You must be pre-planned. What is my planning schedule for tomorrow's studies? So till then, thank you. Do keep a note over here and let me know that whether the session was really helpful to you or not through your messages. Thank you once again. Lots of blessings and God bless you all. Bye-bye.